There's a study out in JAMA right now that reframes how we think about muscle loss in midlife. And it's not about how you look or even how strong you feel. It's about stroke risk, grip strength, walking pace, muscle mass. Researchers are drawing a direct line from those things to your brain's blood supply. That finding alone is worth your next 12 minutes.
Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host, Nikki, who handles the headlines. Take it away, Nikki.
Thanks, Tony. We've got a good one today. 3 studies, all genuinely worth your attention, and none of them are the usual suspects. Let's start with JAMA. A study published in JAMA looked at the relationship between what researchers call sarcopenia-adjacent musculoskeletal decline, muscle loss, reduced grip strength, slower walking pace, and stroke risk. Not heart disease broadly, not cardiovascular events as a catch-all. Stroke specifically. The findings are pretty direct. Each of those 3 markers, muscle mass loss, weaker grip, slower walking speed, was independently associated with a higher risk of stroke. Not as a combined syndrome you have to hit all 3 of, but each one carrying its own signal. Now, if you've been following along with this show for any length of time, you know that the connection between menopause and muscle loss is not new information. Estrogen plays a real role in muscle protein synthesis and in how the body maintains lean mass. When estrogen drops, so does the body's efficiency at holding onto muscle. That's well established. What this JAMA study adds is a specific neurological stake to that conversation that I think gets underplayed. We talk about strength training for bone density. We talk about it for metabolism, for weight management, for mood, all legitimate. But stroke risk, that's a different kind of urgency. Stroke is the number 2 cause of death globally and a leading cause of long-term disability. And this research is pointing at the same physical markers that middle-life women are quietly losing ground on, often without knowing it's happening. Grip strength is interesting because it's so mundane. It's not a dramatic test. You squeeze something, a clinician measures how hard, but it keeps showing up in research as a surprisingly reliable indicator of systemic health. It's been associated with cardiovascular outcomes, cognitive decline, and now stroke. Some researchers treat it almost like a biological speedometer for how the body is aging overall. Walking pace is similar. We're not talking about marathon training, slow walking pace relative to your own baseline or relative to age-matched norms is emerging as a genuine health signal, not just a fitness observation. My actual position on this, I think the framing around strength training for midlife women still leans too hard on aesthetics and body composition, and not hard enough on this kind of functional longevity. The conversation is improving, but the dominant cultural message is still about how you look. This study is one more piece of evidence that the stakes are considerably higher than that. The evidence that your doctor would look at on a tool like Open Evidence is increasingly pointing in the same direction. Muscle preservation in midlife is a medical issue, not a fitness trend. If you're not already doing some form of resistance work, that's the takeaway. Not because it's fashionable, because the data keeps pointing at it from multiple directions, and stroke is now one of them. Completely different subject, but one that comes up constantly in the menopause community and almost never gets researched with any real nuance. A study just published in the NAMS journal, Menopause, looked at sexual function in couples between the ages of 50 and 70. Cross-sectional design, which means a snapshot, not a longitudinal follow-up. But here's what makes it notable. They looked at both male and female factors and how each influence the female sexual function, not just the woman, the couple. The conclusion is almost aggressively logical once you hear it. Female sexual function in midlife is shaped by both partners' physical and psychosocial circumstances. Male factors, erectile function, his own health status, his engagement, matter to her experience. And yet the overwhelming majority of the clinical conversation, the treatment market, the therapy frameworks, all of it defaults to treating this as the woman's problem to solve. This isn't a criticism of individual clinicians who do take a couples-based approach. Some do, but as a structural norm in how we talk about and treat midlife sexual difficulty, it is almost entirely framed around her body, her hormones, her psychology, vaginal dryness, low desire, dyspareunia. The interventions are hers to navigate. And often she's navigating them alone, sometimes in 5-minute appointments, sometimes without her partner even knowing she's struggling. The couple's lens finding is not groundbreaking in the sense that it contradicts anything we'd expect. Of course, a partner's health and behaviour influence the experience, but having it documented in a peer-reviewed study matters because that's what eventually moves the needle on clinical guidelines and how practitioners are trained. It gives clinicians who already intuitively know this something to point to. It gives researchers a direction to keep going. Cross-sectional design is worth flagging. It can tell you that two things co-occur, but not much about direction of causality. Still, the direction of inquiry is right, and I'd like to see a longitudinal study follow this up. The third item today is a pilot study, and I want to be transparent about what that means before we get into why I find it worth discussing. Pilot studies are small. They're designed to test whether something is worth studying at a larger scale, not to prove a thing definitively. Your small sample sizes mean wider confidence intervals, more noise, less certainty. So I'm not presenting this as established fact. I'm presenting it as a signal worth watching. The study is from the Menopausia, Salud, Corazón project, menopause, health, heart. And it looked at midlife Latina women. Specifically, it examined whether psychosocial factors and menopause symptoms were related to hair cortisol concentrations. Hair cortisol is interesting as a biomarker because it captures chronic stress, not acute stress. A blood draw or a saliva sample gives you cortisol at one moment in time, which fluctuates wildly depending on what you did that morning. Whether you slept, whether something stressful just happened. Hair cortisol averages your stress hormone exposure over weeks or months, depending on the length of hair sampled. It's a slower, more integrated signal. The research question was essentially, do psychosocial stressors and menopause symptom burden show up in this long window stress marker? In Latina, women specifically. Latinas are dramatically underrepresented in menopause research. That's not a small problem. If the evidence base is built primarily on white women, which historically a lot of it has been, and if there are meaningful differences in how stress, symptom, burden, and physiological markers interact across demographic groups, then we're making clinical recommendations for populations we don't actually have data on. That's a real gap, and it has real consequences for care. This pilot doesn't close the gap, it opens a door. But opening the door is the necessary first step, and the Menopausia, Salud, Corazón project doing that work in a community that's been left out of the research room matters. What I'll be watching for is whether this gets resourced into a larger study. The biomarker approach is smart, the population is underserved, and the question, how does accumulated psychosocial stress interact with menopause symptom burden, is one with enormous clinical relevance. If chronic stress is measurably shaping how menopause presents, and if that relationship varies across populations, that has implications for how we screen, how we treat, and who we actually design treatment protocols for. The pilot says this is worth pursuing. I agree with that read. Word count, approximately 1,230 words spoken.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.